Welcome to Stream of Conscience, brought to you by Democracy for America, Fairfield County, where we believe that change is possible and you can make it happen. I'm your host, John Hartwell. Our guest today is Kevin Counihan, CEO of Access Health Connecticut, the health insurance exchange, an organization set up to implement the Affordable Care Act, also called Obamacare, here in Connecticut. The exchange is a health care marketplace whose purpose is to increase the number of people covered, improve quality, and drive down costs. Kevin Counihan was appointed by Governor Malloy in July last year and has held senior positions in the healthcare industry during his 30-year career. Most recently, he was president of Choice Administrators in California, and before that he served as chief marketing officer for the Massachusetts Health Insurance Connector, which was set up to implement universal health care under Governor Romney. Kevin, welcome to Stream of Conscience.
Thank you, John. Pleasure to be here.
So Kevin, how is the Affordable Care Act going to change healthcare here in Connecticut?
Well, I think in probably several ways. One is, I think we're going to have more people insured than before. We have about 344,000 uninsured residents in our state, which represents about 9.6% of the population. I think one of the most immediate metrics we'll see is a decline in that. What that decline is at this point, I think is too early to say, but I think that's one. I think the second is that we're going to be creating a more transparent shopping experience for small businesses and for individuals. So they'll be able to compare health insurance plans in an easier and simpler way. All the research shows that small businesses and individuals find buying health insurance to be confusing, complicating, and expensive. And frankly, they don't really understand why it costs as much as it does. I think one of the byproducts of the ACA is a better understanding of transparency of those drivers of costs. I think the third thing is competition. There's a new health plan, a new not-for-profit coming into the state, Healthy CT, which is being sponsored by the Connecticut Medical Society. They'll be offered on the exchange. There is a new nonprofit from Massachusetts, Hartford Pilgrim, that may not be on the exchange in 2014 because they're not licensed yet and they're still building their provider network, but they should be on by 15. And I think, the more competition that we get from other health plans coming into the state, the more I think we can drive increased value for our residents.
The Affordable Care Act, Obamacare, had as one of its goals to reach, if not 100% coverage for health insurance, as close to that as possible. And you're saying that here in the state today, we have about 9% of our population, 9.6, almost 10%,
correct.
Uninsured today. I'm assuming that's mostly because of cost. And perhaps because the market is, as you said, a little bit confusing. So how is Access Health CT going to help drive down cost?
Well, it's a great question. In and of itself, it does not drive down costs. The Affordable Care Act is largely a distribution opportunity. There are sections of the Act that promote certain things such as accountable care organizations, patient-centered medical homes, other forms for providers to be more efficient and to focus in on quality, such as the subsidies provided for electronic medical records. So there are a number of things that are in the Act that really help promote more efficient, higher quality care at a lower cost. To be honest, I believe that the results of those initiatives take years to do. And to be quite frank, I think the implementation of the Affordable Care Act is going to take years to settle down. There's tremendous expectation, and frankly, to me, sometimes unrealistic expectation about what the law is going to do immediately. For example, there's an expectation in some quarters that costs will be cut by 20%, that there'll be no uninsured, and that's just not the case. But I think what we will see over the next 3 to 5 years is a decline in the uninsured, more competition, a better drive towards transparency of how to buy insurance and what makes up the price, which all should lead ultimately to better value.
And So how many insurers do you have participating in the exchange, and what's the basis for letting someone in or not letting someone in, and what kind of products they offer?
There are, at present, 5 insurance companies have submitted non-binding letters of intent. And those LOIs essentially mean that they're kicking the tires on whether or not they want to participate. Whether we get all 5 or not, I think is a little unclear at this point. I think we're going to get the majority of them. We're working very hard and collaboratively with them to make sure that we're an attractive option for them. They're going to be offering products on 4 metal tiers: platinum, gold, silver, and bronze. Those represent actuarial values of what percentage of a series of healthcare costs are paid by the insurance company and what then are paid by the insured. So for example, if one looks at the silver tier, which has a 70% actuarial value, it essentially means that on average, 70% of an insured's costs will be paid by the insurance company, and 30% will be paid by the enrollee or the insured, up to an out-of-pocket maximum.
So these plans, though, are they being specifically tailored for the healthcare exchange, or are they simply programs that these insurance companies are taking off the shelf and plugging in?
It's a little bit of both. The law requires that each state establish something known as Essential Health Benefits, or EHB. And basically what that is a minimum standard of coverage by which any insured person who has healthcare coverage or insurance coverage below that level is actually considered by the government to be uninsured, and in essence would be paying a penalty as if they were uninsured. So the health plans are going to be offering products on a standardized basis for each of the tiers. Again, that bronze, gold, silver, and bronze. So make it very simple for enrollees to compare.
So if there's a bronze plan, it's going to have exactly the same components for each one of the insurers that are providing it.
Correct.
And so then the only differentiation would be cost and network.
Other features, service, value.
So there's a minimum set of features, but then the insurer could add some extra features at that particular level.
That's correct.
Okay.
And on top of that, each of the insurance companies are then going to be able to offer an optional plan or a customized plan of their own choosing by metal tier. So for example, again, if we take the silver tier, there'll be one set of benefits where each participating health plan will be providing the same coverage.
Right.
At the same time, each health plan will then have the ability to customize a new plan. So it's what we call 1+1.
Without those basic benefits, or in
all of them have to have the basic benefits.
So any silver plan has to meet a certain level of basic benefits.
That's correct.
Okay.
And then on top of that, they could add extra benefits. They could perhaps use a different network of providers. We want them to be creative. We'd like them to use the exchange as a laboratory for new thinking. And to be frank, most of the carriers are excited about doing so.
And the negotiations around cost, are you doing anything with the insurers to try to reduce the cost of each of these basic tiers?
Yeah, I think we're actually doing a lot. The Affordable Care Act, number one, promotes competition. We are looking, as I said earlier, to try to get as many plans to participate as possible, because the experience that we've had both in Massachusetts at the connector and in California at a private exchange is that the marketplace works best. The more people competing, the better the value is and the better the price is for the consumer.
But you mentioned early on that one of the reasons why some people are not insured is because of the complexity of the market. And
Correct.
It sounds like this could end up being relatively complex if you have 5 tiers and 5 providers and they're doing 2 plans or 3 plans at each level. That also sounds like it could be fairly complex for someone who is not accustomed to dealing with the insurance market and somewhat naive in how to approach these things.
Well, to be frank with you, I would think that offering one for people that are naive and unsophisticated about the insurance market, one plan is already complicated. So the category itself of health insurance is by definition complicated.
It is.
So the standardization of plan design, at least in our experience, goes miles with respect to simplifying decisions. because it takes away a key issue that is always very confusing, which is, where are the gotchas? Where's the fine print? Where's the little hidden, oh, we don't cover that part? It reduces dramatically that element, which is very pro-consumer and very helpful with respect to people that are just trying to understand, like frankly all of us are. The other thing, again, as I said, I think is the transparency piece. We're going to have quality ratings shown. There's going to be the ability to understand the coverage better. There will be links directly to the participating health plans. And our call center will also serve as a means to help educate consumers and small businesses about coverage.
So are people, when they call in or they go on their computer, I assume most of this is going to be done on the internet?
I think the majority will be,
Mm-hmm.
but there'll be people that will be calling,
Mm-hmm.
and there'll be people that will be using brokers and navigators to get information as well. So we're taking enrollment via the web,
Mm-hmm.
over the phone, and in print.
Are you having any offices of your own?
Um,
Any offices out in the state?
No.
No.
But we will be working with DSS, who does have offices throughout
Right.
the state
Okay.
as a distribution arm.
And so you'll be delivering services through DSS or delivering information.
Exactly.
Yeah.
And we'll also be working with hospitals throughout the state,
Mm-hmm.
physicians' offices throughout the state, community health centers. There's a whole network throughout the state for distribution.
And so if I'm a person who today cannot afford insurance for whatever reason, you're going to be bringing insurers together who will be offering these various tiers, and they'll have basic elements in each one of the tiers. It'll be transparent. It'll be easy to understand, hopefully.
Easier to understand.
Easier to understand.
Yes.
Figure out how to negotiate and navigate through that system.
Correct.
But I still don't have any money.
Right.
What do I do?
Well, in the instance of people that don't have any money, they will most likely be eligible for Medicaid. And for those folks, as you know, that works really up to 138% of the federal poverty level, which is about $15,000 for an individual. For those folks that are above that level, and frankly, that's where, to your point, buying health insurance becomes very, very expensive and acutely expensive. The law provides subsidies from the federal government up to 400% of the federal poverty level, which is about $92,000 for a family of four.
So I'm a family of four, and I'm making $50,000, $60,000, and I'm living in Middletown or
Correct.
someplace like that. And I don't have a health insurance today because my company doesn't provide it, and maybe I'm self-employed, and so there we are. So I'll be able to get a subsidy from the federal government.
Correct.
How does that work?
So the subsidy will be determined based on something known as modified adjusted gross income,
Mm-hmm.
which is essentially a line on the tax form.
Mm-hmm.
So from someone's 1040 or 1040 EZ, they'll be able to put their income into our website along with demographic information and family size. The system will calculate if they're A, eligible for subsidies, and B, what that subsidy is.
Okay.
So that will be a systemic calculation.
So I take last year's tax return, and I find this adjusted gross income line,
Right.
and then I plug that into your website,
Correct.
and with other information, and then you tell me how much I qualify for in terms of subsidy.
That's correct.
And then how do I actually get the money or get the subsidy?
So just to give you a quick overview of the process,
Mhm.
when you put that into the computer system and press enter, that information goes to basically two sources. One is to the federal government, where it's reviewed by the Treasury Department and IRS, by Homeland Security, and by Social Security to validate citizenship, the income, and things of that sort. It also goes from the state level to the Department of Social Services, the Department of Corrections, things of that sort to validate eligibility issues on that part. If you then take that subsidy, and let's use dollars for example. Let's say, for example, an individual was interested in a plan in the silver level of, I'm making this up, $700 a month.
Mm-hmm.
But with the subsidy, it reduced that amount to $400 a month. So the $300 are paid by the federal government.
Mm-hmm.
The federal government will be taking that individual subsidy, that $300, and be paying it directly to the insurance company selected by that enrollee.
At the time that the policy is in fact in force. In other words, I'm not having to wait for my tax return next year
No.
to get some kind of
No.
rebate from the
No.
government. No.
It's called an advanced premium tax credit.
Okay.
Because it is done in advance.
Okay.
Yeah. Now, let me just give you, you pointed to some of the complexity of the law. And let me just give you an example of that. If, for example, someone, to your point, was making $56,000 and living in Middletown, applied for a tax credit of a certain level, and it paid that, the example that I gave, which was $300 a month, right?
Right.
The difference between the $700 and the $400,
Right.
right? But it turns out that individual, through good luck, good fortune, something or other, received a big year-end bonus. It might put that individual above $56,000, say into $65,000. They may go into a separate level of subsidy. They would have to pay the government back the difference.
So there's some sort of clawback by the
Correct.
on the part
There
of the
is a
government.
reconciliation if there's an income variation. Yeah.
Yes. Okay.
Yeah.
All right. So and that would be done at tax time
Yeah.
or
Yeah.
through. Now, what happens if someone decides that I don't want to deal with this? Government take over healthcare, not my idea of a good time,
Right.
and I'm just not going to play ball. What happens?
Right. Essentially what happens is several things. One, obviously, the person's uninsured.
Yes.
Number two is that they would pay a penalty. And that penalty in the first year is very, very modest, of $95. It goes up to a couple $100 in 2015. And it reaches a point, I think, in 16 or 17, where it can be a maximum of about 2.5% of that person's income. So it's very, very low. So they would pay that penalty as part of the filing of their tax return. For people who want to verify to the IRS that in fact they are insured, the insurance companies will be sending out something like a 1040HC, or it will be a form attached to the tax return that verifies from an Anthem, a Connecticut, an Aetna, that in fact they were insured.
So everyone who is insured is going to be getting another form from their insurance company at the end of the year.
Correct.
That you include then with your tax return.
That's correct.
Tell the IRS that yes, you are covered.
Correct.
Wow, it's an amazing amount of bureaucracy in the background to make this thing run.
It's actually not that much. I mean, it may sound that way. And again, I'm just using my prior experience in Massachusetts.
Sure.
But for the past, 6 years now, or 5 to 6 years now, that's how it's worked in Massachusetts. It's been a pretty simple process.
And when you were in Massachusetts,
98% compliance in that state.
98% compliance. You said earlier, before we started the show, every child in Massachusetts is now covered.
Correct.
And
98% of people are covered.
98% of people are covered, 100% of children.
Correct.
And what we hear from people who oppose the Affordable Care Act is that this is going to bankrupt the country. What's been the experience in Massachusetts? What was when you were there 4.5 years? You were a central part of that operation.
Right. Well, that's not been the case in Massachusetts at all.
Mm-hmm.
The Massachusetts plan has got its own complications from funding. It basically occurred under Governor Romney's administration, where he was able to get a Medicaid waiver from HHS, Health and Human Services, through a relationship that he had with the Secretary Leavitt at the time, Mike Leavitt, as an experiment, really to try this out.
Right.
So that's not been the case in Massachusetts. I hear that issue that you've mentioned quite a bit, and I think it's too early to say. Will this cost the country money? Absolutely. Is it something we can afford? To me, it's an issue of value. It's a values-based issue. And I think this is one of the challenging parts, to be quite frank with you, about the ACA implementation, which is, I don't think there's a right or wrong in health reform. In part is that it would be best if the country could be fairly unified about the concept that all people should be insured. Because if we're divided on that issue, then we get divided on a lot of the details and the specifics. If we get unified on that issue, fairly unified, we can kind of work out those issues because it becomes a core value, like defense, like education, public safety. We're not totally unified on that issue yet.
No.
And that's a huge complication here.
How is that complicating your implementation here in Connecticut?
Well, having just come back with a conference with 17 of my peers, I think it's a complication, in all the 18 states that are implementing state-based exchanges like ours, which is just that, the term itself, Obamacare, is very polarizing.
Right.
So
it was intended to be.
Well, maybe. Yeah, you're right. That it was. And both Romney and Obama hate, despite what they say, they hate having their names related to that. But people, you mentioned the term, right? And people will have a reaction, either often pro or against, without knowing anything about it, right? So some of the people who are in favor actually don't know that much about it. A lot of the people that are against it don't know much about it. It just has this sort of dynamic reaction. That's very hard, just because people don't really focus, I think, on the implementation as much as it's just, big government. You had mentioned earlier a big government takeover of healthcare. It's frankly just the opposite, which is why the insurance company stocks went up and the pharmaceutical stocks went up after it passed. It's very much using the status quo. It's extending the status quo to 32 million people. But it frankly, John, it really works best when you've got a sense of shared responsibility by all stakeholders, individuals, small businesses, large businesses, the legislature, policy people, physicians, hospitals. What frankly worked with us well in Massachusetts was, in 2006, there was this sort of kumbaya attitude that this is important. This is a value for our state residents, and we have to work together to make it work. I don't think any state's in that position right now, so it's tougher.
And the people who, as we mentioned a moment ago, decide to stay out of the system and pay the $95 the first year and a couple hundred the next year and whatever, are they still going to be allowed to go to emergency rooms and get free care?
Yeah.
Yeah? So initially, the requirement to get covered is a little soft.
Yeah, it is. And I'm just speaking personally here. I'm not speaking for the administration. Okay. I'm not speaking for Access Health. This is just my own personal opinion. I'm not speaking for the governor or our board. It's too low. It was a political compromise to get the thing through.
Right.
Our experience in Massachusetts was that it doesn't really have teeth until it hits that sort of $1,000 or so range. You get people's attention at $1,000.
Sure.
$95.
Who cares?
Not much.
Yeah.
So, it does escalate up. Ideally, would it be better to be a little bit higher first year? In my opinion, yes. Maybe others would share something differently.
Okay. And you mentioned that there are only 18 states that are doing a state-based exchange. That leaves, 32 states that are not. Why are we so out of balance here?
Well, there's a bunch of reasons. There are three kinds of exchanges, by the way. There's the state-based, which you made reference to. Mm-hmm. There's the default exchange, which is the exchange for the states that wish the law was never passed, wish the court ruled differently,
right.
Wished Obama didn't get reelected,
right.
Wish this could have been like the last episode of Dallas where JR came back or something. They just wish this whole thing didn't happen. Right. Whole thing's a dream, bad dream. Right. And then there's a hybrid called the state partnership. That's where the feds do a piece and the states do a piece.
Oh, okay.
To your point, there are 18 states doing the purest form of the ACA or Obamacare, which is what we're doing.
Right.
And one of the challenges around it is just it's a 3-year IT implementation being done in 10 months.
Yeah.
So
it's huge.
It's really complex.
Yeah.
And it's an integration with DSS. It's then,
and with all the healthcare providers in the state.
That's correct. And it's interfaces with the feds.
Yeah.
It's interfaces with the state.
Yeah.
It's very, very complicated. And I think for some states, they said, this is a little bit too much for us to take on right away. We'd like to just wait a bit.
So it wasn't resistance, it was reluctance to be on the leading edge.
It depends. There was some states.
There's some that clearly are resistant.
Yeah, there was some. There's some clear resistance, but there were some that just said, I think I'd like to see how this works.
So what's the timeline here in Connecticut? We're now in early February. The Affordable Care Act takes place in 2014,
correct.
Right? So people have to sign up before then, get into the plans. How are you doing all of this?
So we're scheduled right now to have our website functional by October 1st.
Okay.
And the law prescribes for the first year that the open enrollment period be 6 months, that it run from October 1st, 2013 to March 31st, 2014, retroactive to 1/1/14.
Right. Okay.
So we're to be frank with you, John, our whole goal is to get a functioning website up and running that where individuals can have access to the participating plans, where they can put information into the system, where it calculates in real time what category of coverage, Medicaid, subsidy, non-subsidized, that they're eligible for, that we have a vibrant small business product available, which we're also going to have. Some of the bells and whistles that we wanted to put in the first year, we're not going to be able to because we don't have enough time.
Don't have enough time.
But they will be in the second year.
Right.
But we want to make sure that the basics are covered, and then really communicate, which is actually as much a challenge as the IT development, is the outreach.
I would
it's
think so.
very, very
Absolutely.
complicated.
Yeah. It's a huge community you're serving.
But I would tell you, and I know this may sound hokey, but I don't mean it to be. I actually feel more confident each month, where I thought it was going to be the other way around. We've got a very good team of very hardworking people here. We've got a good group of vendors that are supporting us. We're getting good support from the key stakeholders within the state. You know, I'm very happy to be here. I think this is just a wonderful state for a bunch of reasons. And people are very supportive of what we're doing by and large. So I'm very optimistic that this is going to be a good experience for people.
Well, I'm glad, because we obviously need more health care for more people, and we need it to be as inexpensive as possible and to be efficient and effective as possible. Kevin, thank you so much for your time.
Thank you, John.
And maybe we'll come back as this get a little closer to implementation and talk again.
I wish you would.
Thank you.
Thank you.
That's our show for this week. We hope you enjoyed it. You can catch all our shows on YouTube by going to youtube.com/user/DFATVnet. We're also on Facebook and Twitter, and you can send comments or suggestions for a show to info@dfa-tv.net. If you'd like to learn more about progressive political action, we meet on the first Wednesday of the month at 7 p.m. at the Silver Star Diner in Norwalk. We'd love to have you join us. Remember, change is possible, and you can make it happen. This has been Stream of Conscience. I'm your host, John Hartwell. Thanks for watching.